Sudden fear, intense apprehension, terror, severe physical and psychological symptoms. For many people, this is a threatening world. In this program, we'll look at a common and serious condition from the perspectives of the patient, the primary care physician, and the psychiatrist. With guests Dr. Robert Pasnow, professor of psychiatry at the University of California, Los Angeles School of Medicine and past president of the American Psychiatric Association, and Dr. Harry Metcalf, clinical professor of family medicine at the State University of New York Buffalo School of Medicine and past president of the American Academy of Family Physicians.
Well, it was physical pain as far as your heart feeling like it's about ready to jump out of its chest. And it really hurts. It's like it's in a knot, like someone's taking your heart and squeezing it, and your heart is going crazy.
I get like a buzzing in my ear. Okay, my ears will start ringing. You have to kind of pull yourself together. You don't know where you are. You start hyperventilating. You're losing the oxygen to your brain. You start, you're real lightheaded. You start getting, your chest just feels like it's being crushed.
Well, my only thought was I'm having a heart attack. And fixing to pass out, all I could do to even, my only thoughts were just trying to inch the car back to the office.
Your hands start sweating, your feet start sweating, you start sweating. You just have sweat, pouring off of your forehead, sitting there in a nice, cool restaurant somewhere, and this starts happening to you.
That's not even the scariest part of what's going on with your body. It's what's going on in your mind. You really feel like you're losing your mind.
You just want to run and get away, and there's nowhere to run, there's nowhere to go, and it's totally incapacitating. It's the worst fear that you can experience.
They just did not let up. It was every day I could count on at least one, and sometimes a day there would be 3 and 4 a day.
Sometimes 2 or 3 an hour, at my worst.
It'll scare you. You think you're dying. You think you're just losing your mind. You don't know what to think.
Those are really the commonest complaints that the patients will present with when the person is having a panic attack. And as we know, the panic disorder is one of the 7 anxiety disorders, all of which are a common form of mental illness, but specifically the panic attack is also one of the commonest of those anxiety disorders. There's very important, significant aspects of panic attack, and that is that it's a very common type of a disorder. As you can see, that there are several mental disorders that everyone will face throughout a course of a lifetime. But when you look at anxiety disorders being 14.6% as a lifetime prevalence, and when you look at alcohol abuse as also being a very significant lifetime prevalence disorder, we need to put panic attack in perspective. And of the anxiety disorders, panic attack is one of the most significant ones, especially because of its presentation and its intense feeling that the patient has at the time when the panic attack begins. The classical symptoms of shortness of breath, dizziness, palpitations, trembling or shaking, and sweating. We know that these things are the classical symptoms. Can you tell us a little bit about the biochemical basis for this, Bob?
Well, sure. There's probably biochemical, learned, cognitive, and even psychological etiology for this disorder. The biology is very interesting, and we've had a lot of recent research in biology. The part of the brain that seems to be most implicated is the locus ceruleus, and many of the people with panic disorder seem to be very sensitive to those drugs, or caffeine, for example, that stimulate the locus ceruleus. The locus ceruleus contains about 70% of the norepinephrine neurons in the central nervous system, so the locus ceruleus is important, and we've shown that the beta blockers and some of the benzodiazepines also affect those receptors in the locus ceruleus. We've also know that benzodiazepines have another mode of action, which we'll talk about later when we talk about the benzodiazepines. But GABA, the gamma-aminobutyric acid, which is a inhibitory neurotransmitter in the brain, is very much affected by benzodiazepines, and benzodiazepines play a role in regulating that system as well. I think the most impressive to me of the recent stuff that I've seen has come from Ryman's laboratory, his PET scans of patients who have lactate-induced anxiety attacks, showing an increase in temporal polar blood flow, which occurs at this time, and also in normal anticipatory panic or anxiety. And more interesting than that is the observation that panic disorder patients who are vulnerable to lactate-induced panic attacks have several abnormalities in the non-panic state. They have an abnormal asymmetry of blood flow, blood volume, and metabolic rate for oxygen in the vicinity of the posterior parahippocampal gyrus. And we know that genetic factors do play an important role in all of this. And in taking a family history, one often finds that a first-degree relative has had panic disorder and hasn't been diagnosed, and it's kind of an underdiagnosis. So we have here a situation in which we have biology, genetics, learning, and psychodynamic all put together. A very interesting situation.
I went to 3 or 4 emergency rooms, and they just said, "You're fine. We can't find anything wrong with you."
I went to a lot of specialists as far as a cardiologist, an endocrinologist, you know, things like that, to keep ruling out anything physical. And they checked everything out as far as my thyroid and EKG, and everything came out normal. And that bothered me a little bit, because I thought, well, it can't be normal. You know, something's wrong with me.
EEGs, EKGs, anything you could run, they ran, and there was just nothing there. So then's when they started saying, okay, what's going on emotionally?
When he was asking me about my personal life, I was telling him it was pretty unstable at this point, okay? And he said, well, that's the problem. You just, you know, it's your emotions. You need to just find another job.
It wasn't just stress. I knew something else was going on, but that was the part that was frustrating, is you can't get anybody to believe you.
The suicide rate of agoraphobics and panic attack individuals is very high, because they go to these doctors, to the professionals that we feel, you know, are the ones that are going to help us. We pay the big prices. You just expect them to know what's wrong and to take care of you. I went to 8. I don't know if I would have gone to 10 or 9.
You know, Harry, those patients on these film clips are so classical of the kinds of problems that we encounter in clinical practice when we see patients in consultation and when they come into our office, usually after a long string of frustrating experiences with the medical profession. Why is this important for primary care medicine and family practice?
Well, I think it's especially true for the family physician to recognize the fact that a patient with a panic attack, when they present, needs to be recognized immediately and make a correct diagnosis, and then proceed to care for that patient properly. It prevents the natural history of the disease from progressing into the true panic disorders and the many variations that can involve the hypochondriasis, the phobic avoidance, the depression, and the suicide. And that we know is a very significant part of a sequence of panic attack that goes on and on without being properly treated.
Well, you know, I was impressed with the patient who commented that panic disorder patients commit suicide. He's absolutely right. As a matter of fact, it appears from some of the latest data that even surprised me, and I've been working in this field for a long time, that panic disorder patients are more likely to attempt suicide than patients with major depression. Perhaps 20% of patients with untreated panic disorder will make a suicide attempt, as compared to about 15% patients with major depression, and with neither disorder, only 2%. So it's a significant morbidity and mortality, perhaps higher than any other mental disorder that we know about. About 28% of all people with panic disorder have used the emergency room in the past year, and have been told, as many of these people on our film clips, that there's nothing the matter with them. And of course that leads to frustration and feeling of despair as well. And finally, I think we have to look at the comorbidity of alcohol use and panic disorder, and see that about a third of the patients, close to 30% of patients who have panic disorder, use or abuse alcohol. And that increases the costs also, and it provides a real major problem for us in the treatment of patients with panic disorder. What are some of the more common presentations that you've seen for patients?